Hello again, everybody. It's Patrick. It's after work. It's Sunday, and it's about 11:15, maybe a little closer to 11:30 in the AM. Can you believe that? I only had one visit on my caseload today. Somebody that I've been seeing pretty often because of decline and stuff like that. And but I'm on call for the next 20 hours, or next 20 and a half hours. So that should be pretty interesting. Not only am I on call for the next 20 and 1/2 hours, there's an all-staff meeting tomorrow where they're going to talk about the plans we have to build an inpatient hospice unit right next to our office. So that's pretty exciting. I guess it's still in the feasibility stage right now, feasibility study stage or something like that. I guess I'll be updated more about it tomorrow. But that's a pretty interesting idea. I'd definitely take a position in that facility if it opened. I think that would be a cool thing a cool place to work at, because I think the closest inpatient unit for hospice to here is on the other side of the state, like maybe like 45 minutes away, maybe an hour away, something like that. But that's going to be tricky. I'm going to have to try to manage my sleep and rest a little better than usual, because I tend not to sleep very well on nights when I'm on call, because I'm paranoid I'm going to miss the phone. So at the end of my on-call shift, the all-staff meeting is right after that. And then at 11:30 in the morning, I've got I got an appointment with a phone advising session with my advisor at Sacred Heart, where I'm going to try to appeal to her to do something with my course of study, because what I'm doing right now is a joke. Yeah, I'm liking having a caseload right now. I'm like kind of putting a lot of the pieces together now that I'm seeing the same people week after week, and kind of anticipating what they're going to need a little bit better. So that's been fun. One of the home health aides today had an emergency and had to call out in the middle of her shift, which had us scrambling to try to find the on-call and trying to reorganize everybody's schedules and stuff. That was one of those little administrative things, those little hiccups. Sometimes we have to do that kind of administrative managing stuff. I've noticed I've been giving a lot of enemas lately. That was something that just occurred to me the other day. I've been giving more enemas and suppositories than usual, and I'm just constantly surprised at how difficult it is to get information about bowel movements from hospitals. It's like we had this one patient who came back from the hospital, and the caregiver, like the woman who takes care of her every day, she's very organized and she keeps track of everything. She writes down all her vital signs and how much fluid she takes in and how much fluid she puts out, and does a bowel training regimen with her and like all this other stuff. So she's like super organized. So when she told me that she didn't know when this patient last moved their bowels, I was kind of nonplussed, So I called the hospital to figure it out, because she had just gotten back from the hospital the day prior, and nobody seemed to be able to tell me. It was difficult information to find. Nobody that I talked to knew how to find that information, which is, critically important. It's a very important piece of info to have, and it was not on the discharge summary. And everybody that I talked to seems to think it would be on the discharge summary, but in fact, at this particular hospital, I know from experience that information is never on the discharge summary. It's just not a piece of info that people put on it, much to my eternal annoyance. So, after a polite reminder to the woman in medical records that fecal impactions are a sentinel event, they called me, a little bit later and told me that this patient had a bowel movement the day that they came to the hospital, but didn't have any more bowel movements the whole time she was there, which I think was like about a week or so. So, after 3 days, you should really do something, to prevent a fecal impaction or, some kind of serious side effect. And it just wasn't done. And this is a pattern that I see over and over and over again. I mean, when patients are in the hospital, and their caregivers see that they're DNR and they have dementia and they don't really know what's going on. Little things like that tend to get missed, and it's kind of infuriating because those are the people who are the most dependent and most at risk for problems related to these kinds of things. So you would think, if anything, that would make people more diligent about those kinds of issues. But it's just something I see over and over again. You know, like the development of bed sores, untreated constipation, inadequate pain management, and it's almost like when people see elderly DNRs with dementia, they're just like, why is this person here? Why are they wasting a hospital bed? And that's really unfortunate. And you know, in a limited sense, I kind of see where they're coming from, because, you know, if possible, that person should be somewhere besides a hospital, because nobody should be in a hospital. But, you know, while they're there and they're admitted and a doctor is certified that there's a medical necessity for them to be in the hospital, there's no reason why those people shouldn't get care that's just as good as people who are likely to complain and sue them later. But there you have it. I got a really puzzling call from another hospital during my on-call time, when somebody wanted to make a referral, and, you know, when I explained that we couldn't admit somebody over the weekend because we don't have administrative backup or financial support, or you know, there's like administrative office stuff that needs to get done that I don't know how to do. The person was alarmed. They're like, oh, but, you know, we have to call you because this person's going to go to a nursing home and they're comfort measures only, and we need you to advocate for them, and we want to make sure they get pain medicine. And, you know, I mean, there was another call that caused me to be a little nonplussed, because, I mean, if somebody is in pain and you're not giving them pain medication, then you're abusing them. You know, like, that's abuse. Specifically, it's elder abuse, but abuse is abuse, you know. So I'm kind of confused why it's on us to make sure that patients that are in the hospital are getting the kind of care that's obviously appropriate. And you know, I don't get called to consult at the hospital physically as often as, you know, we have full-time hospital liaisons who go there all the time and consult. I only do it every once in a while, like when they're out. But I'm really, really surprised at how undertreated pain is. I mean, I've seen people that are just in agony, you know, like breathing 50 or 60 times per minute, skin's falling apart, immense pain, not able to talk. And you know, there's been occasions where I've had to walk up to the nurse's station and, you know, just ask this nursing supervisor politely to please get this person on a morphine drip, you know. And then, you know, I'll follow up and, you know, get a report after the fact just for my own knowledge, and find out that person was rushed to the ICU and died 12 hours later, you know. So, I mean, you know, it's been like 60 years since On Death and Dying was written by Elizabeth Kubler-Ross. And in that book, she describes how difficult it was to get doctors to acknowledge the existence of patients who are dying. No, nobody's dying on this unit. No. You must have us confused with somewhere else. No, nobody's dying here. So, I mean, it's just really bizarre to still, 60 years later, witness that level of denial in trained medical professionals, you know. I mean, these people are MDs and registered nurses and certified nurses' aides, and, you know, people who are experienced professionals that somehow think that they don't have to do anything until we come in, you know. Well, the hospice nurse, you know, well, we can't put her on morphine until hospice comes and sees her, you know. Not that anybody said, like, exactly that, but that's kind of the impression that I guess sometimes. And that's just really puzzling to me. I mean, you'd think a facility with so many highly trained and educated people that they would have a system for this, you know, that they would have some kind of handle on, you know, the ethical and the practice standards of their own professions. But this is often not the case. You know, a lot of the time I see nursing homes do a better job of this than hospitals. So maybe it's something particular to hospitals that I'm just not clued into yet, because I only go there as a consultant. I've never worked a floor assignment. And now that I have a full-time job in hospice, getting a floor assignment on a hospital is not as big of a priority as it was 2 years ago, or 3 years ago, or 4 years ago. At the on the advice of my clinical faculty in school, you know, that was, you know, my number one priority, trying to get that med-surg rotation and get a year or two under my belt as a floor nurse in a hospital. But you know, now that I'm a full-time hospice nurse, I'm not itching to do that, really. So one of my coworkers at hospice told me that she's really getting a chuckle out of my clinical reports, just like the wording that I use and the way I compose sentences. There was a couple of sentences that they found particularly amusing, in sort of like a dry sense of humor way or whatever. I didn't really mean them to be funny, but they were funny to them. Nothing, you know, was like, you know, disparaging or demeaning. You know, it was all very plain and matter of fact, you know, to my mind. But somebody else reading them, you know, would find them hilariously funny, and I don't know, that's kind of neat. One example of this was one of the many enemas that I've given in the last week. I wrote in my note that the results of the enema were ongoing. You know, they were just continuing to happen. Somebody thought that was really funny. And then in another note, you know, there's this really tricky thing that I run into where I'm told I'm not allowed to document that I provided any training to a hired caregiver. Like, some people have these hired private duty caregivers that are in the home 24 hours a day. I'm not allowed to document that I trained them or instructed them in anything. I have to document that I trained the patient or a family member, like the POA or something. But a lot of the times the patient's not teachable, or the power of attorney is not present, and the person that we're relying on to provide care for this person is the person that I have to instruct in these things and make sure they know how to do them. But I can't document that I did that, you know. So there's this one note that I wrote where I wrote that I instructed the patient to keep the commode at the bedside and one of the bed rails down instead of climbing over the bed rail, because this patient fell. And the way that I'd worded it seemed extremely funny to one of my coworkers, but part of the reason for that was that wasn't exactly an accurate reflection of what happened. I mean, I did discuss it with the patient also, but that person can't be expected to remember or implement any of that stuff because they're not independent. The person that I was really making sure understood to do this was the 24-hour caregiver, but I'm not allowed to document that that's what I did. So there's a lot of subtleties of the documentation I'm still, you know, trying to get hip to. It's very confusing. Well, I guess that's it for now. If anything interesting happens on my overnight shift, I'll record another video then. But keep your fingers crossed for me that nothing interesting happens in the next 20 hours. That is what I'm hoping.